Our last speaker of the morning here, before we go into our panel and then some lunch, we're going to shift away from the adult athlete into the pediatric athlete. So Dr. Matt Breiding has been at the Center for Disease Control and Prevention since 2005, and then he shifted over to the Division of Unintentional Injury Prevention in 2014, where he serves as a traumatic brain injury team lead. In that capacity, he has worked with the team to develop the National Concussion Surveillance System and the CDC's Pediatric Mild TBI Guidelines. Please join me in welcoming Dr. Matt Breiding.
Good morning. I have an admission as well that I may have left something out of my bio. I not only attended Ohio State, but also Notre Dame, and so however, you have nothing to fear. I know many University of Michigan grads, my brother, my wife, my father-in-law, and then much of her extended family. So I promise we will all get along. That often makes for some interesting Thanksgiving dinners with the big game coming right around that time, but we've found a way to manage that. So that's not what I'm here to talk about. I am here to talk about some pediatric mild TBI guidelines that CDC spent a very long time developing. And much of that has to do with the fact that when you put the stamp of approval of the federal government on some recommendations, you need to vet those in many numerous ways to ensure that they're of the highest scientific value, that the public has an opportunity to comment, that they're vetted up through the various levels of the agency to ensure that they meet high standards. And so just to place where we sit, I lead the traumatic brain injury team at CDC, and we're in the Division of Unintentional Injury Prevention. And it just happens to be that many of the other topics that are covered in the division are some of the leading causes of traumatic brain injury. So older adult falls and motor vehicle injury. And then of course, opioid overdose is also become a very big topic as well. Within our center, there's a division of violence prevention, and that is also another major source of traumatic brain injury. So to give you an idea about what we focus on at CDC when it comes to traumatic brain injury, we're an applied public health agency, and some of the things that we're most known for are public health surveillance, which Zach talked about earlier, as well as primary prevention, trying to prevent a health condition from occurring in the first place. And so our first two priorities are really about surveillance, finding ways to better quantify the burden of traumatic brain injury, not just sports concussion, but the full range, full age range as well. And so, as Steve mentioned, we're working to develop a national concussion surveillance system, and a lot of that is geared toward providing more comprehensive estimates of TBI, as well as TBI in youth. As Zach mentioned, we don't have a lot of data about how frequent TBI or concussion is experienced by those below the high school age when it comes to sports concussion. And so we're attempting to do that and do that better. Our third priority is primary prevention of youth sports concussion. A lot of the other major causes of TBI have other folks working on them: older adult falls, suicide, motor vehicle crashes. Other areas at CDC work on those. Our niche is to work on primary prevention of sports concussion. And in fact, one of the groups we funded was Zach's group to develop some primary prevention programs to keep concussions from happening in the first place. And so we're very excited about what he and his team are going to come up with. Where the pediatric guideline fits is in our goal of improving diagnosis and management of mild TBI. Many of you are probably, if you're athletic trainers, are familiar with CDC heads-up materials, which are going on about 15 years now. We've updated them as the science has evolved. And so the pediatric guideline I'll talk about today fits within that, that particular goal. And then we have two new goals, two recent goals that are to identify and to develop an evidence base for return to school or return to learn practices, that often kids who have ongoing symptoms after a concussion, they're best treated by having somebody in the school watching out for them, monitoring them, reporting back to the parent, having a feedback loop, a communication with the physician, with the child's doctor. And so developing evidence to support that that is beneficial to a child. And then finally, understanding and addressing the challenges of TBI in rural settings. Much of the research we've done are in suburban, urban areas. Well, what happens if you're making a recommendation, as we do, to refer to a specialist after a certain period of time, but there's not a specialist to refer to? So how do you handle that? And so we're doing a number of studies of rural providers to understand that better and to possibly adjust our guidance. So the CDC Pediatric Mild TBI Guideline, the goal was to improve diagnosis and management of mild TBI or concussion amongst those 18 years and younger. And we intended to do that by conducting a systematic review of the literature, as well as to create evidence-based clinical recommendations. Much of the guidelines that have been developed previously were consensus-based guidelines, or they were focused on sports concussion. This is a guideline that's focused on mild TBI of all causes, as well as is also evidence-based, and so that was our goal. Now, as I mentioned, the actual development of the guideline was quite lengthy. There's quite a lot of steps that we need to undertake in order to release a guideline. So our injury center has a board of scientific counselors, and they came up with this idea and developed and identified a work group. The work group nominated a number of clinical questions and voted on them to select those questions that the evidence-based review would examine. The group conducted a literature search, reviewed the literature, and then rated that particular evidence as to the strength of the evidence, with a random RCT being at the highest level of evidence that they would rate. They developed recommendations and voted on those recommendations, and then they presented a work group with those recommendations back to our board of scientific counselors. From that, we developed a number of manuscripts. Those went through a review process at CDC, as well as the Department of Health and Human Services. We put it out for public review, put it out for peer review, sent it to the journal. They sent it to other peer reviewers, and then finally it was published in September of 2018. So the work group that developed the recommendations was a multidisciplinary group of anyone who is involved in the treatment of pediatric mild TBI in children. And so we had neurologists, we had neuropsychologists, we had nurses, we had athletic trainers, the full gamut, emergency doctors. And so we had 21 work group members who engaged in the voting, 21 ad hoc experts who were consultants, and then a number of federal representatives to weigh in on the guidelines. And in the end, the work group identified 6 critical clinical questions. The first having to do with what specific tools accurately diagnose mild TBI. And the second and third having to do with what can we do to identify important intracranial injury? And that's the kind of thing beyond a concussion, something that might alter the short-term management of a TBI. And so how often does imaging identify important intracranial injury? And then what other factors, clinical factors, identify important intracranial injury? The fourth and fifth clinical questions looked at prognosis. And so what predicted a longer outcome within a year, and then what predicted a longer outcome beyond a year. And then finally, number 6 was what treatment or management strategies have been shown to be effective for mild TBI in children. So just to give a sense about what studies were included in the literature review, children who had a Glasgow Coma scale of 13 to 15, they could be with or without intracranial injury, and we include the full age range of 0 to 18 years of age, because often pediatric providers will see children through their 18th year. And then for each of those 6 clinical questions, they had specific inclusion criteria. So in terms of the methodology, the systematic review and guideline were developed using methods that are approved by the American Academy of Neurology, and it was compliant with 2010 standards of the National Academy of Sciences. So to give you a sense about The entire science that we examined, or that the work group examined really, 37,000 abstracts were examined, about 2,900 full text articles were reviewed, 340 articles underwent data extraction, and almost 100 were included in the systematic review as meeting the criteria for sufficient scientific rigor. So in summary, the guideline represents 25 years of scientific research. It represents the most comprehensive review of pediatric mild TBI scientific evidence to date from about 1990 to 2015. And it's so far the only U.S. evidence-based clinical recommendations. And it's meant to cover all causes of pediatric mild TBI, not just sports, and includes guidance for acute care as well as primary care. So in terms of the scope of the recommendations, when it comes to diagnosis, there were recommendations made in the categories of risk factors for intracranial injury, the use of imaging and when that's merited, neuropsychological tools that are useful in diagnostic purposes, as well as the use of serum biomarkers. And then in terms of prognostic recommendations, we provide recommendations related to the counseling of prognosis, prognosis related to premorbid conditions, looking at the cumulative risk of those various risk factors and what that says in terms of clinical care, as well as assessment tools and prognosis and interventions for TBI for those with poor prognosis. And then finally, a number of management and treatment recommendations related to patient and family education, cognitive physical rest, as well as when children should get back to aerobic activity, the kind of support that parents and teachers can provide, the kinds of recommendations that physicians should make for that, return to school processes that are beneficial to children, and then a number of areas related to treatment, headache management, vestibulo-ocular motor treatment, sleep management, and cognitive impairment treatment. And so in total, the work group made 47 recommendations, which we boiled down into kind of those 19 areas that I just covered. And so I just want to highlight 10 of, I think, the most important recommendations, which combine a number of the individual recommendations, but really highlight the kinds of things that we want to convey. And so first, the guideline does not recommend imaging of patients for the purposes of diagnosis. Instead, the guideline recommends that clinicians use existing decision rules, such as the PCARN decision rules, to determine whether children are at higher risk for intracranial injury and whether imaging is warranted. Instead, what is recommended for diagnostic purposes is using validated age-appropriate symptom scales, not in isolation, as others have mentioned earlier today. Multiple tests should be used, but that should form the core of any diagnostic evaluation, is a validated age-appropriate symptom scale. And then we recommend that clinicians assess for evidence-based risk factors for prolonged symptoms, and that they use these validated prediction rules. I think Chris mentioned some of those earlier today, where you combine those to determine whether someone has a high, medium, or low risk for ongoing symptoms to adjust the kinds of recommendations that are made in the clinical setting. And as others have mentioned earlier today, the guideline recommends counseling patients to return gradually to non-sports activities after no more than 2 to 3 days of rest. And so very light activities like walking. I think I'm repeating one there, but so I'll move on to number 7. So another recommendation is to counsel patients to engage in a graduated return to activity protocol that is focused on avoiding symptom exacerbation. And we have a number of materials on the CDC website about how to go about those various steps. Perhaps some of you are familiar with those. And if symptoms do not resolve within 4 to 6 weeks after standard care, then in particular primary care physicians should consider referring for additional assessment and or specialty care. And then in terms of returning to school, it's really important to counsel students and their parents about gradually increasing the duration and intensity of the activity, to plan for them, to give them a plan that's customized to their symptoms, to encourage them to engage in collaborative monitoring with their teacher, the school nurse, the athletic trainer, the coach, talking to the parent, ideally that information feeding back to the child's doctor, and that's the best case scenario for a child. And that school-based teams, if possible, should assess for the needs if there is a prolonged recovery and adjust the accommodations that the child needs in school, and then refer for formal evaluation if it's for prolonged symptoms. And then finally, if particular symptoms are persistent, such as headache, recommends multidisciplinary evaluation and treatment. For vestibular ocular motor dysfunction, vestibular rehab. For sleep problems, refer to a sleep disorder specialist. And then for cognitive dysfunction, a formal neuropsychological evaluation. So at CDC, we're an applied public health agency, and one of the things that we talk about a lot is that just doing the science isn't enough, that we need to get recommendations like these into the hands of clinicians. And what really drove this home for us is that one of the folks on our team, their child had a concussion recently, and they were advised by the physician they saw to engage in strict rest, which is obviously not what we're recommending. And so we can make these recommendations, we can put them in a journal, we can try to put materials on our website and promote those as much as possible, but if it's not actually ingested, read by those who put it into use, then they're no good. And so that's really the part that we were working on before we released the guideline, and we will continue to work on today. So to date, the guideline was covered by 51 news outlets and had over 100,000 page views. We sent it out to our distribution list of 100,000 recipients, and then started working with a lot of partner groups to get the word out about these guidelines. We developed a number of implementation tools, and we engaged a process to ensure that they were maximally useful for those who are likely to use them. Physicians, this is predominantly a clinical guideline, but it could have an impact on parents, coaches, athletic trainers, school nurses. And so initially we translated the key findings into a set of educational products, and then we conducted formative testing with the particular audiences they were geared toward. When we launched the guideline, we also launched these implementation materials so that as folks heard about it, they had materials they could use to apply the guideline recommendations. And then we worked with many partner organizations to get these materials out and into the hands of clinicians, athletic trainers, school nurses. So getting into some of the implementation tools we developed, most were geared toward healthcare providers. The one you see here is a checklist that a number of things a clinician should do to assess, counsel, and then refer. Some of the things that they should think about. Developed a number of screening and assessment tools. Put some of the key recommendations in at a glance, which many clinicians refer to when they see patients, and then developed a number of fact sheets. And so here's the fact sheet we developed that outlines the diagnostic recommendations. That's just the first page. It's a couple pages long. Another one for the prognostic recommendations, and then another one for the management and treatment recommendations. We also have had a clinician online training on the diagnosis and management of mild TBI. And so in the process of updating and rebranding that training, we added in the guideline recommendations and made that available in November. So far, about 4,000 clinicians have taken the training. So it offers free continuing education credits and is one of the ways in which we're trying to get the word out about the guideline recommendations. We developed a number of implementation tools that were geared toward parents. a set of discharge instructions, as well as some symptom-based recovery tips. So ideally, these are some things that a clinician could print out and hand to a parent, things that hopefully are attractive enough, unlike most of the discharge instructions I've ever received, that a parent might actually want to sit down and look at. And so explaining what a concussion is and the kinds of things that they should look for and how they should respond. Here's another look at the recovery tips handout. Also developed a number of implementation tools for school professionals. So a letter for clinicians to fill out, to send through the parent to the schools that outlines the particular symptoms. There's a larger look at it. The symptoms on the left that the child is currently experiencing, as well as a number of checkboxes that outline the types of accommodations that the clinician recommends given the particular symptom profile. And so, again, we're always trying to figure out ways to bridge between the medical and educational systems for children, because they, unlike adults, have to manage those too. A lot of their health care is managed or monitored in the school setting, and so this is one potential link. We developed a number of specialty-specific commentaries that focused on the particular recommendations that were most relevant for a number of different specialties. I think 7 of the 9 have been published, and about 2 more are in progress. So it's just another way to get out to clinicians the kind of information that we want them to have. And then one of our most popular educational tools is a training for coaches. About 4 million coaches have taken our online training that helps them to recognize the signs of a concussion, as well as how to respond. And so we're updating this training to the extent that it applies to coaches with some of the guideline recommendations. But we're expected, I think, to pass about 5 million coaches this fall when we have a flurry of coaches that tend to take our trainings, many of which are directed by the return to play laws in various states. And then we have a number of plans for continuing to disseminate the guideline. We see this kind of as an ongoing effort. And so we're developing some trainings for school professionals, in particular about those return to school recommendations, and an online training for athletic trainers. We noticed that 20,000 athletic trainers have taken our coaches training, and so we thought it would be good to develop a training specifically geared toward athletic trainers and the kinds of things they need to look out for. And so we're in the process of developing that. All of that, again, consistent with the guideline recommendations. We're planning to evaluate the guideline in various clinical settings to assess the degree to which it's adopted and the degree to which that might perhaps change either process or health outcomes for children. And we're examining the feasibility of recommendations for rural providers in a qualitative and a quantitative study, having them examine the recommendations and identify which ones might be more challenging to implement in a rural setting. And then that'll lead us to possibly developing some materials geared toward rural providers that take into account some of the particular challenges they face. We're currently engaged in evaluating a number of return to school programs. So as I mentioned, that's a key area of focus for us, that we really think that a lot of kids are in some sense neglected after they return to school, that 15 to 20% that have symptoms on an ongoing basis, and often they slip through the cracks. And so there are a number of state-level programs. Pennsylvania has a very good program that helps to identify those kids and then follow them over time and make sure that they receive the accommodations and services they need, and that there's a feedback loop to their primary care physician. And so we're evaluating those to demonstrate, hopefully, that these improve outcomes for children over time after they experience a TBI. And then finally, we've developed some teleecho programs. It's kind of a telehealth system, but it's primarily for clinicians where they're able to use video conferencing software. And it's been particularly effective for a number of health conditions in rural settings, where often clinicians do not have a community of practice, other physicians they can talk to about this. And so we think this is particularly important as it relates to TBI and managing TBI in kids. There may not be the specialists around them to refer to, and so they may be having to manage, we think they're managing this all by themselves. And so being able to consult with other clinicians in rural settings about how to handle this. And all of this, again, is in accordance with the guideline recommendations. And so we've developed a number of those as a way of also getting the word out about these recommendations. So in closing, I'd just like to acknowledge the many folks who worked on the guideline and developing the guideline. It was a huge effort involving many people. First, the lead authors, Angela Lumba Brown and Keith Yates, who for their leadership in kind of bringing everybody together, as well as Kelly Sarmiento on my team. And then finally, the list of guideline authors. Chris was an author on the guideline. Thank you, Chris. And anyone else out there who may have participated. I haven't met all of the authors, but thank you to these authors for all of their work. Thank you.